We heard about the protective measures that all the personnel should take in order to avoid contamination with SARS-CoV-2 virus. And we also heard about how the antenatal screening is done under this COVID-19 environment. And we will finish this session by talking about childbirth and breastfeeding in women with COVID-19 infection. So all these things happened very quickly. We heard that during Christmas time that there was an infection, a viral infection in China. And before we realized that that was a big problem in China, then it was spread throughout the world. So under the World Health Organization now it's called pandemic. The World Health Organization is emphasizing that before, during, and after childbirth, all women have the right to high-quality care, and this also includes women with COVID-19 infection. However, not all the agencies and the scientific societies agree about how to manage women who have COVID-19 infection. And this makes sense because this is a bright new virus, and we do not know what is the best way to manage and have the delivery and breastfeeding in these cases. So, as we heard from Dr. Papaioannou earlier, pregnant patients with known or suspected COVID-19 infection should notify the obstetric unit prior to arrival, so the facility can make appropriate preparations and wait for them to arrive. And why this is important is because some women may be symptomatic, but a large proportion of pregnant women are asymptomatic, yet they have the virus. In a study that it was published lately in the New England Journal of Medicine, they had universal screening in all women admitted for delivery, and although only 1.9% of women had symptoms like cough or fever, they found that 13.5% of these women were positive, and this was detected by RT-PCR, which is the gold standard, although there is a 30% false negative, as you heard from Dr. Papaioannou. So even with this method, with RT-PCR, 13.5% women were positive for SARS-CoV-2 virus, and they had no symptoms. This is a very serious finding. So we do not say that in every population and in every country this is such a serious problem. However, at least for New York, it means that 1 out of 8 women admitted for delivery, they are positive for COVID-19. So for these women, we have to take special care how they arrive, especially if a pregnant woman is getting into labor. Then usually we prefer that they will come by emergency medical services, because what is normally happening, her husband is driving to the hospital. However, according to the instructions that we all have, is that a person who is near a positive patient should stay at home at least for 14 days. So the husband is staying at home, and the most safe way for the patient to arrive is by emergency medical services. And actually, in this case, the driver should contact the emergency department, so we are all ready for this patient to arrive. According to the guidelines, we do not test only for COVID-19, but it is also suggested that we should also check for influenza and RSV, because sometimes we can have some of these infections as well. And we have seen here at Attikon Hospital one patient who was also infected by influenza. And there are protocols And you heard from Dr. Papayannou that we should have deep nasopharyngeal and pharyngeal samples, otherwise we may have a false negative result. So according to if a test is negative or positive and if there are symptoms or not, a patient who is not getting into labor, they can stay at home, or if they have symptoms, they have to hospitalized and in a separate unit for COVID-19 patients, or if there are severe symptoms, they should be even in the intensive care unit. But what is the mode of delivery for women who are at term and they are getting into labor? In fact, it has been suggested that if a patient is getting into delivery and she's before 24 weeks, or in case that she is in severe maternal illness, sometimes they say that we should consider termination of pregnancy because of the severe case of the patient. And some of the medications that are used in the intensive care unit, they may be contraindicated, or there may be a very severe situation for the patient's life. Fortunately, in Greece, the pregnant women who got into labor, they were not in such a severe condition, and all the babies that they have been born so far, they are pretty well. So when a patient is at term, guidelines suggest that we first go for a vaginal delivery. However, although SARS-CoV-2 virus was not found in vaginal secretions, we know that it has been identified in both anal and urine samples, and that means that there is no way to avoid maybe contamination during vaginal delivery. However, this is suggested by many scientific societies to try for vaginal delivery unless it is very difficult or contraindicated. In the first instruction that I have been given, it was to have early clamping of the umbilical cord in order to avoid contamination. However, newer advices, such as the one that is shown here, they say that the delayed clamping, which is the usual rule, is possible. And also no early cleaning of the newborn, and the newborn surveillance should be in isolation. Initially, the first instructions in Greece, they were to test for pregnant women only if they had symptoms or if they have traveled in areas where there is contamination with this virus. However, since May 2020, the instructions are for screening in all women admitted for delivery. Although it is not so serious, the infection in Greece as in New York, I'm not sure if the publication in the New England showing that 1 out of 8 women is positive for SARS-CoV-2 virus made the officers to advise this, but I think it was a wise decision. So far in our hospital, 3 women were admitted for delivery, and 5 women were followed up during pregnancy. And actually during this period of time, 82 women were tested negative by RT-PCR. So this is the medical team of the first delivery. We were informed that the patient who was with a confirmed COVID-19 infection in another hospital was sent to our unit because we are a referral center. And as I mentioned earlier, the emergency ambulance was bringing the patient to the hospital, so we were informed. And this is how the personnel was getting ready according to the instructions that Dr. Evangelinakis mentioned earlier. And this is how they were ready and waiting for the patient to arrive. And in fact, here is the first patient that she was also in a good condition. She was not having very serious symptoms. She only had fever and cough, and she had actually a large baby. She had fetal macrosomia, and for this reason there was a decision to have the delivery by a cesarean section. For the second lady that she arrived in our hospital, she also had a confirmed COVID-19 infection tested elsewhere by RT-PCR, so we were also informed in this case. And she had in her history 2 previous cesarean sections, so for this reason the delivery was also done by a cesarean section. And finally, the third lady, we know in advance that she was positive for SARS-CoV-2 virus, and we were monitoring her with non-stress test weekly. And we knew that she was positive for 3 weeks, and she remained actually positive by RT-PCR because we were checking her every week to see if she becomes negative, so we would not have to take these precautions. So she remained positive for this virus, and she has spontaneous rupture of membranes at 38 weeks. So we were getting ready for vaginal delivery. And for this reason, because we were checking her dilation, we didn't have to take the extra measures with the Tyvek, as Dr. Evangelinakis showed you earlier. We were only wearing these precautions. However, after 8 hours, we found that there was a failure to progress in labor. So even in this lady, we finally decided to have the delivery by cesarean section, and this is how we were dressed by the Tyvek uniform. What about the newborns? And I have to tell you that all 3 newborns in our hospital, they were negative by RT-PCR in SARS-CoV-2 virus. So infants born to a pregnant woman with suspected COVID-19 infection for whom testing is unknown, either pending results or not tested, are not considered to be infants with suspected COVID-19. So in this case, we keep them in a room with the mother. However, we have them in a 2-meter distance, the one from each other, until we have the results, the pending results from the mother. However, infants born to mothers with known COVID-19 infection at the time of delivery, as it happened in all 3 cases in our hospital, should be considered infants with suspected COVID-19, and as such, infants with suspected COVID-19 should be isolated from other healthy infants. Here I must say that World Health Organization and other scientific societies suggest that if the mother does not have severe symptoms, or she is asymptomatic, positive for SARS-CoV-2 virus but asymptomatic, the mother and the newborn can stay in the same room. However, there should be a curtain between the mother and the newborn, and there should be a distance at least of 2 meters. So far, we have decided to have the babies in a separate in the intensive care unit of the neonates, as you can see here. And here you can see the 2 out of the 3 babies that they were born. The one baby is here and the one baby is here with a 2-meter distance, and have them monitored closely by the neonatologists. And as I mentioned before, the RT-PCR examination in the amniotic fluid, the placenta, and the pharyngeal swabs of the babies were negative. What about breastfeeding? The World Health Organization and the Royal College of Obstetrics and Gynecology suggest that if the mother has not severe symptoms or she is asymptomatic, by taking protective measures, she can breastfeed. However, COVID-19 infection is a major problem, and we have seen babies that they had this infection. So we take major precautions, and actually even in the guidelines that they have published in the Lancet Infectious Diseases, they suggest that it should be discussed by an interdisciplinary team, including neonatologists, pediatric infectious disease specialists, and infection control team and obstetricians. In our hospital, at least for the first cases, we have decided not to have breastfeeding with the mother when she's RT-PCR positive, but wait for that until she gets 2 PCR examinations negative. And the reason is because although the mothers that we had so far had mild disease, at least the 2 of them, there was one study showing that there was a neonate in China that had IgM antibodies, and we know that IgM antibodies do not cross the placenta, and this may implicate that the baby had the disease during pregnancy or after labor. And also there have been some other studies showing that the mothers were infected, and actually then the neonates were infected as well. So despite that the World Health Organization and the Royal College are suggesting that we can have the mother breastfeed the baby, because it's not, we didn't find in the milk of the mother the virus. However, it is very easy to have the contamination, so we prefer to keep the babies safe. So in our hospital, the breastfeeding is suggested after the 2 negative maternal RT-PCR results. And in fact, the mothers are preferring this way, because the moment that they have the baby and they breastfeed, they know that they are safe and their baby will not have the infection. So this is a new situation. It is a severe situation. We had women in the 2nd trimester with pneumonia, and we had some problems. So we do not take it easily. We have to take precautions. Maybe the precautions that we are taking and separating the baby until the mother is RT-PCR negative, maybe it is too much. However, for the time being, this is what we prefer. Maybe we are discussing right now that if the mother is asymptomatic, to keep the baby with the mother, because as I mentioned for the previous cases, the babies were in the intensive care unit of the neonates. Maybe we can keep them in the same room with a curtain and a distance of 2 meters. However, this is something that we will try to do it with very close steps. Thank you very much.